Assalamu alaikum everyone. Good evening. I would like to welcome you to our second Young Leader Forum for tonight. Our topic for tonight will be about the clinical curves in the management of diabetes from elderly, DKA, and the pump. To start with, I would like to thank our sponsor for tonight, Servier. Few housekeeping announcements as we are starting. That our session for tonight is live streamed on EDS YouTube channel. The webinar will be also available on demand on ADS Institute website and the ADS YouTube channel. If you're having any questions during the webinar, you can share with us your questions in the Q&A box. If you faced any technical problems joining our webinar for tonight, you can write your questions on WhatsApp and our technical team will help you. Just to remind you, our webinar for tonight is a CME accredited by DHA. So starting with our Young Leader Forum, we're having 4 excellent speakers for tonight. 3 of them will talk about clinical topics and one of our speakers will talk about an academic topic. We'll start with our first speaker for tonight, Dr. Budur Al-Imadi. Dr. Budur Al-Imadi is a specialist endocrinologist from Dubai Hospital. She completed her fellowship in endocrine and diabetes from King Faisal Specialist Hospital and Research Center from Riyadh, PSA. She's ECNO certified and UK specialist certificate in endocrine and diabetes. Dr. Budur is going to talk about the highlights in the management of diabetes in elderly. Dr. Budur, mic is yours. Please feel free to unmute yourself and share your slides.
Thanks, Dr. Asma, for your kind introduction. Assalamu alaikum jami'an. Good evening, everybody. So my talk tonight will be to give highlights in the management of diabetes in elderly. I have no disclosures. So the objectives of my presentation for tonight, first I'll start with a screening recommendation for this category. Then I'll move on to what are the essential components to be assessed in elderly prior to starting framework. Then I'll be talking about what is the framework in determining the clinical targets in elderly. Then we'll speak about frailty and sarcopenia and their role in the management of diabetes. Then I'll move on to the implication of the cognitive impairment in the management of diabetes in elderly, and what are the risk of hypoglycemia in elderly. The other objective will be speaking about the unique glucose patterns noted in elderly and its clinical implication. Finally, I'll touch some points on the management of diabetes in elderly. So the group of people that I'll be speaking tonight is people whom age are 65 and above. So is there any difference in the recommendation for screening for diabetes for such group? It's the same as middle age. The fasting plasma glucose and or the HbA1c, and if it's normal, the Endocrine Society advocates for repeating it every 2 years. Now, if the screening met of any of those screening met for the pre-diabetes stage, this will be followed by the oral glucose tolerance test, but the oral glucose tolerance test will be if the patient meets the high risk profile, and the high risk profile that we're talking about is the same that applies to the metabolic, to the middle age, when we speak about if there is underlying different metabolic disorder like dyslipidemia, hypertension, smoking, history of cardiovascular disease, obese or BMI, obese or overweight. Now there are some pitfalls in the HbA1c in elderly, because some of them you may encounter people with having underlying iron deficiency anemia. So this So the pitfall here will be that it will falsely elevate your the HbA1c, and some of them have underlying chronic kidney disease, and the uremia will alter the RBC lysis, so the HbA1c might not accurately reflect their blood sugar. Now, what are the essential components that we have to address prior to starting the treatment? There are two. The first is assessing the overall health, and the second is looking at the patient's personal value. So what I mean by this is it's an individualized treatment. So what's the points that I have to look when looking at the patient's overall health? So there are general health and diabetes specific health. The general health, when we talk about the general health, we're talking about the cognitive. We have to assess the cognitive presence of dementia or no. Second, we have to look if there is a mental illness like depression. The third essential component is looking at the functional, assessing the functional status of that elderly, dependent or independent. Then we look at the risk of fall, comorbidities, and we see the sensorium level, the vision, the hearing, the balance, and if there is a history of fall. For diabetes specific health is that we are screening for recommendations and for if they are capable of self-management at home. So what do I mean? One of the essential components is assessing the functional status. Just to remind the rest of the audience, the 5 essential components in the activity of the activity of daily living. I have given it an abbreviation of BDIT that stands for assessing bathing, dressing, eating, toileting, and transferring, whether dependent or independent, and the 5 other components for the instrumental use in the activity of daily living, that is preparing meal, shopping, managing money, using telephone, managing medication. And those questions should be actively directed to the patient or the caretaker. Now, we come to the core of the presentation, that is the conceptual framework when considering treating patients above age 65. Now, this table, the credit goes to Caroline Blom. Caroline Blom is a geriatrician with many publications in the field of geriatric. The credit goes to her on setting up this diagram to guide the clinician, the management of diabetes in elderly. This was adopted by the American Diabetes Association in 2012, and it was used again in the Endocrine Society Guideline 2019. So what Caroline said, that for group 1, to say that this is a good health, that either they have no comorbidities or less than 3, and if there is no cognitive impairment and the functional status is good, and if they require assistance, it will be in the instrumental use. We go to the extreme, that is the poor health. When we're talking about the comorbidities, we're talking about end-stage comorbidity. If we're talking about dementia, we're talking about advanced dementia, and the functional status patients start to require assistance in their activity of daily living in 2 or more components. The intermediate is somewhere in between. They have chronic illness more than 3, but not to the degree that it have reached end stage. The cognitive impairment is just mild, and they require for assistance in the instrumental use, but still the 5 essential components of the activity of daily living is intact. So how do we translate this into clinical practice? Is by determining for each group what is a safe HbA1c. So for the healthy group, it's like middle-aged young, you will target below 7.5. For the group 3, that is the poor health, you will target the first half of 8, so up to 8.5% is acceptable. And for the intermediate, you will target below 8. So the second question comes whether they are using medication that have a high chance of hypoglycemia. If your patient have a medication that is having a higher chance of hypoglycemia, even if they are in the good health group, target toward a higher blood sugar at home to avoid hypo. So for the good health group, the daily blood sugar measurement, they advocate that it reaches up to 100, mid-100, does not exceed. For the people in the poor health, you can see that for the fasting and the bedtime, it almost approaches 200. And if they are on medication that have a higher risk of hypo, then it crosses 200 little. Frailty, What is frailty? Frailty is increased vulnerability of that elderly to physical and psychosocial stressor. What do I mean by this? Frailty is an age-accelerated decline in many organs of the system, of the body, that will collectively reduce the homeostasis of that patient and prone him to negative adverse outcome. Just remember that frailty is not a passive thing that the elderly will speak about. You have to dig in the history, and it's dynamic process that you have to assess each visit. There are many scores that is used for frailty assessment. One of them is that just in the clinic, ask the patient to get up and go and see the gait speed, the balance, and the grip strength. If you don't feel comfortable, you can refer your patient to geriatrician who are specialized in this field. Now, sarcopenia. Sarcopenia is another disorder that is seen in elderly. Sarcopenia is a diffuse progressive decline in the function and the bulk of the skeletal muscle. So it's an aging process. If you see, and if your parents having diffuse skeletal muscle loss, then this is a strong sign of sarcopenia. There are many scales. One of them, because the scales are examining the proximal and distal muscle strength. So to see, one of them is to ask the patient how difficult do you lift things? Do you need assistance in walking, raising from chair, climbing stairs, and falls? This is all to assess the power and the function of the muscle. Now let's move to the cognitive impairment in elderly. It's very well known that the dementia, that the cognitive impairment of diabetes, it's because of vascular pathology rather than the plaque and the tangles that is the hallmark of Alzheimer. So diabetes is not only a risk factor for patient to develop mild cognitive impairment, but it's also a risk factor that puts the patient at risk of converting the mild cognitive impairment to a full-blown dementia. Now, again, like frailty and sarcopenia, this is not something passively that you will get during the interview. You have to question the patient. The screening is done every 2 to 3 years if they were normal, and if you find some abnormal results, then the screening should be annual. What's the implication of this? One, it will impact the patient's self-management of diabetes. It will be poor at home. For the hospital, it will increase the frequency of admission and the cost, and will make the patient more prone to hypoglycemia. By the way, cognitive dysfunction and hypoglycemia both have, they are bidirectional. Cognitive can put the patient at risk of hypoglycemia. Hypoglycemia can worsen the cognitive impairment. So how do we clinically translate this in the management of diabetes? So the expert panel of diabetes, they have recommended that someone if have mild to moderate cognitive impairment, target HbA1c do not up to 8%. If someone have advanced cognitive impairment, then target up to 8.5. So you can see they are using Caroline Bloom framework that someone with advanced cognitive impairment belongs to group 3, where we stretch and lax the HbA1c up to 8.5. Now, let's move to another topic, hypoglycemia in elderly and falls. There are multiple studies documenting the risk of hypoglycemia in elderly to induce fall. And they have analyzed what are the highest risk factors in elderly to induce fall. First, the more the advanced the age, like 70 and above, the presence of cognitive impairment, presence of organ damage like renal impairment, use of SUs and insulin that put the patient at risk of hypo. Now, we're not talking about just simple hypo. These studies have documented that the elderly, when they are at risk of hypo, this hypo can result in a traumatic hypo that can result in a fracture or a disability, not just a simple fall. Now we keep on saying we have to avoid hypoglycemia, which is a critical strategy in the management of diabetes in elderly, but still the overall goal is to prevent hyperglycemia. And the reason that persistent hyperglycemia put the elderly at risk of dehydration, electrolyte abnormalities, urine infections, dizziness, and falls, and they can put them at risk of developing acute diabetes complication like DKA and HONC. And by the way, developing acute hyperglycemic complication in elderly have a higher mortality rate than when middle age or a young person develops such acute complications. Now let's move on to the unique glucose patterns that is seen in elderly. This is a very nice study where they divided they have recruited a large number of elderly, and they have divided them into two groups, age below 65 and above, and they watched them at baseline and 24 weeks follow up, and they have measured 7 points of blood sugar throughout the day, and they have found that both at basal and at follow-up at 24 weeks, the group of people that is age 65 and above had the contribution of postprandial hyperglycemia more than basal hyperglycemia. So in elderly, postprandial hyperglycemia contributes more than basal hyperglycemia that was found in this study. Now let's translate this into clinical practice. So knowing such pattern means you have to tailor your patient, and probably you might need to add a prandial insulin rather than adding insulin, or progressively keep on titrating the long-acting insulin where the contributor is the postprandial and not the fasting blood sugar. So now I'll move on to the management of diabetes in elderly. I'll touch some of the medications. So lifestyle modification, this is for all age categories. Lifestyle modifications remains number one and should be incorporated for each diabetes. Now, and using medical nutrition therapy by a registered dietitian have shown in multiple studies that is clinically very effective if it was an experienced registered nurse. But always bear in mind when you are putting a lifestyle modification, medical nutrition therapy, don't forget in such group to assess for underlying malnutrition. Don't let the hyperglycemia deceive you and not assess the possible underlying malnutrition. If your patient cannot tolerate the medical nutrition therapy, then please do not use restrictive diets for your patient, like keto diets or whatever kind of restrictive diets in such a group, and just simply ask the patient to avoid simple sugar. By the way, if your patient have underlying sarcopenia, then you have to refer to dietitian to increase the protein intake, to increase the bulk of muscle to prevent the negative adverse outcomes. Now let's talk about the famous medication metformin that is in all guidelines as the first-line management and may have a positive cardiovascular outcomes. It's a nice medication because in elderly it has a less chance of inducing hypoglycemia and less chance of weight gain. Now, should we routinely measure B12 in elderly or just based on symptoms? Now, there are multiple studies. The one was a systematic review, and another study done in 27 centers in US where they followed the elderly patients up to 5 years to look at the incidence of B12. And they have seen the longer the duration the patient metformin, the higher the chance of having B12 deficiency associated with peripheral neuropathy. So the Endocrine Society 2019 guidelines, they recommended annual screening for B12 while patient on metformin. Now, SUs, the sulfonylureas glenides, as you know, we have, it's better always to avoid medications in elderly that is insulin secretagogues, but if you need to use, please use, avoid using the SUs that have duration of action that exceeds 24 hours, like the gluburide. Choose, for example, glimepiride or glipizide. Now let's move on to the the most worrisome medications the concern of physicians to be used in elderly in daily clinical practice, that is the TZD, the thiazolidine diones. Now, the incidence of pedal edema with the TZD is dose dependent, and usually if it will cause pedal edema, you will see it with the first few months of use rather than later years, or with the dosage change. Also, you will see it in the first few months most of the time rather than very late. It's a multifactorial, the etiology. One of the suggested mechanisms that the TZDs reduce the renal excretion of sodium, and thereby it will cause sodium and water retention, and some studies have showed that it increases the plasma volume and causes dilutional hyponatremia. Now, is it common to have heart failure? Is it common, the incidence of heart failure with TZDs? Now, despite the recurrent warning about the use of TZDs and heart failure, the epidemiological studies that have examined this relationship, it was there, but it was not that common. When I say not common, I mean it did not exceed 5%. It was very low. The incidence of heart failure with the use of TZDs that many people worry to start is low. Whom are the categories that have the highest risk of developing heart failure while they are on TZDs? Now, this is a summary of multiple studies of the highest risk profile. One, underlying cardiac disease, whether vascular or depression of the ejection fraction or valvulopathy. The older the patient, the longer duration of diabetes, higher dose. As we said, it's dose dependent. And if it was concomitantly treated with insulin have also a chance of fluid retention, underlying kidney damage, or a patient is developing weight gain during the therapy. Now, one would ask that all these risk factors could very likely be present elderly. They have been exposed probably to hyperglycemia for several years, and there might be an element of atherosclerotic cardiovascular disease or depressed ejection fraction or element of diastolic heart failure. So can we use on those, or it's better to be avoided? To answer this question, the American Heart Association, American Diabetes Association addressed this issue and put a consensus in the use of TZDs. So now we have different scenarios. Let's talk about scenario one. In patients who do not have established heart disease, you can start TZD. But saying start TZD doesn't mean that you don't monitor the patient. Always with TZD or with any dosage change, you will monitor for pedal edema, and you will monitor for weight gain, and you will monitor for CHF signs and symptoms. Now, let's move to scenario number two. If TZD was prescribed for someone doesn't have established heart disease, but have risk factors that we have mentioned, again, you can start with low dose. And when you want to build up the dose to achieve euglycemia, do it very gradual and take longer time to optimize the sugar control. Scenario number three, if patients do not have signs or symptoms of heart failure, but by echo, they have a depressed ejection fraction, for example, below 40%. Again, the consensus that has been released by the ADA and the AHA, they did not block the use of TZD, and they said that the physician might consider using it. Again, the dose adjustment should take even a longer. The more presence of heart failure or structural disease, take your time. Be more gentle and longer in titrating the dose. Now, let's say patient have active heart failure, either he is in class 1 or class 2. Can you start? Again, you can, but be very cautious when starting, and be very cautious with escalation and monitor the patient very closely. Now, let's say patient have advanced class of heart failure 3 or 4. No, please, for patients who have active signs and symptoms of class 3 or 4, please do not use the TZDs. Now, as we said, throughout, while patient on TZD, always you have to ask about pedal edema, weight gain, and CHF signs and symptoms. And when you have an edema, when your patient develops edema, check whether it's accompanied by CHF signs and symptoms. And number three, make sure that there is no different etiology. Now, let's say patient developed pedal edema and he could not tolerate it, and it was not associated with CHF. So there are three ways to manage this. One is to prescribe diuretics. Other is to increase the dose of diuretics if it has been used as an antihypertensive medication. But let me tell you that the response with the use of diuretics and pedal edema induced by TZD therapy is variable. So you cannot guarantee the response. It differs from patient to another. The third way to manage is that you lower the dose and you consider another agent to control the hyperglycemia. Now let's go to a different scenario. Pedal edema that was accompanied by CHF, but to start with, the patient did not have a depressed ejection fraction. So now it's clinician judgment whether to permanently or temporarily DC the medications. And the CHF, you will treat it according to standard guidelines. Now let's talk about the third scenario. Someone developed pedal edema that was followed by heart failure, but to start with, he had an evidence prior to starting of the TZDs, evidence of depressed ejection fraction, but he was asymptomatic. No, so since he developed the CHF with the TZD and with underlying depressed ejection fraction, please do not get back to the medication. A quick note about the glucosidase inhibitors. It's a medication that have modest efficacy and generally well tolerated, but many, and it's safe. Many elderly DC it because of the side effects of the flatulence, gastric upset, and loose motion. So there is a high rate of non-adherence because of these adverse events. The SGLT, now the SGLT, if you see the Endocrine Society Guidelines 2019, they indirectly advocate for elderly to use medication that have a high and good profile as in terms of cardiovascular benefit. And the SGLTs, the newer medications, the SGLTs and the GLPs are the one that have a good cardiac profile. So it's advocated to be used in elderly, plus have a lower chance of inducing hypoglycemia. Now, one of those SGLTs that the canagliflozin, there was a study where they compared the dose of 100 versus 300 in someone age 75 and above. And they've seen that people who were in the higher dose, 300, extreme ages, they were at risk of more of dehydration. So please, when you're probably you might consider when someone elderly on Cana, probably better not to go for the higher dose to avoid the risk of volume depletion. So I cannot go through all the medication because my time is limited, and this is only highlights. So I'll just give a brief one slide about the management of hypertension in elderly. Now, there are different guidelines in management of hypertension in elderly with diabetes. There are different guidelines. They're putting different cutoff lines. But the one that I am referring to is the American Diabetes Association, because you might read different guidelines and they are putting a different cutoff points. So in the American Heart Association, American Diabetes Association, for elderly, their blood pressure up to or less than 140/90 is fine. And if patient have underlying cardiovascular stroke or a progressive chronic kidney disease, they go to a lower level and they watch for orthostatic hypotension and such category. And for people whom Caroline Blum have classified as the group 3, the poor health, they consider a bit higher target, like 140 to over 160. Now, the hypertension topic have been addressed several times in multiple series in the EDS Connect, so I'm not going to spend much time on it. This was just some few highlights in the management of diabetes in elderly, and that was my last slide. Thanks for your attention, and I think I'm on time. I'll hand the mic back to Dr. Asma.
Thank you, Dr. Abdur. That was an excellent highlights. No doubt that it's going to be an eye-opener for many of us on how to manage elderly patients with diabetes. Reminder for all attendees, if you're having any question, please place your question in the Q&A chat box, and we'll answer all your questions during the Q&A session. We're moving to our second speaker for tonight, Dr. Raya Mazroui. Dr. Raya is a consultant endocrinologist at Tuam Hospital. She completed her fellowship training in diabetes and endocrinology at Imperial College Healthcare NH Trust, London, UK. She is also a graduate of Harvard Medical School Global Clinical Scholars Research Training. Dr. Raya involved in academic teaching for under and postgraduates. Dr. Raya will speak today about a young man with severe DKA. Dr. Raya, mic is yours. Please feel free to unmute yourself and share your slides.
Thank you very much. Good evening, everyone. Thank you, Asma, for the introduction, and thanks for giving me the chance for presentation today. I will present a case of a young man with a severe diabetic ketoacidosis. And the objective of today's presentation is to give a brief overview about the pathophysiology of DKA, the diagnostic criteria and management.
Can you share your slides, please?
So the objective of today's presentation is to go over pathophysiology of DKA, diagnostic criteria and management, and through a case presentation, hopefully to highlight a relatively new precipitating factor and the difference in such DKA compared to the usual DKA cases, and to highlight the prevention recommendation. So DKA basically is a consequence of lack of insulin and concomitant elevation of counter-regulatory hormones. And this basically results from either absolute insulin deficiency or a relative insulin deficiency, where the level is insufficient to suppress ketone production. And the triad of diabetic ketoacidosis is hyperglycemia, metabolic acidosis, and ketonemia, and it is associated with varying degrees of circulatory volume depletion. Most commonly happen in uncontrolled type 1 diabetes or poorly controlled type 2 diabetes with a provoking factor like acute medical illness or surgical illness. Now, DKA incidence have increased over the last few decades in both type 1 and type 2 based on different cohorts from different countries. The one that is depicted here in the slide is from England, but the same have been found also in US. However, fortunately, the mortality have been decreasing and have been static over the last few years in both types of diabetes. Now, as we mentioned before, the main or the corner of DKA is the absolute insulin deficiency and the increase in counter-regulatory hormones. And this will lead to increase in gluconeogenic enzymes activity, leading to gluconeogenesis and gluconeolysis, as well as decreased glucose utilization, and subsequently hyperglycemia, which leads to osmotic diuresis, followed by electrolyte imbalance and dehydration. On the other hand, the counter-regulatory hormones will stimulate the hormone-sensitive lipase in adipose tissue, will lead to breakdown of triglycerides into free fatty acids and glycerol. And this one will be delivered to the liver, and then it will be consumed in formation of ketone bodies, followed by acidosis. So triglycerides in fatty tissue will be degraded into glycerol, and free fatty acids. Usually these free fatty acids are oxidized in the liver into acetyl-CoA, which then enter into the Krebs cycles and used for the formation of ATP. However, when there is excessive acetyl-CoA, it will condense, form 2-acetyl-CoA or HMG-CoA, and all of this will go through different steps of conversion and oxidation to form the three main types of ketone bodies: acetoacetate and beta-hydroxybutyrate, which are considered keto acids, stay in the blood, cause drop in ketones and cause acidosis, as well as cause ketonuria, glycosuria, and formation predisposed to dehydration. Acetone would go into the lung and cause causal breathing. So we'll start with the case. Our case is a 26-year-old male who was brought to the ER with a 4 hours history of agitation, short of breath and abdominal pain. This was preceded by 4 days of history of fatigue, malaise, fever, and sore throat. He recently joined the National Military Service. However, still he was not engaged on any form of physical training. And his past medical history was significant for being diagnosed with type 2 diabetes for almost 7 years and was following in another institution. And he has been on multiple oral hypoglycemic agents for which he could recall only metformin by name. On physical examination, he was looking dehydrated, febrile, tachycardic, tachypneic, and he was morbidly obese with a BMI of 41. He had a non-oxidative pharyngitis. He had a shallow, deep breathing with a sinus tachycardia. Otherwise, the systemic examination was unremarkable. His initial lab investigation showed a glucose of 13.6 millimole with a biocarb of 4 and a pH of 6.84 with 3+ urine ketones, normal lactate, and therefore anion gap of 34, elevated anion gap, and his inflammatory markers, including CRP, procalcitonin, and WBC count were elevated. So going through the diagnostic criteria for DKA, there are different guidelines from different societies. However, the most commonly used one are the one from ADA, American Diabetic Association, and UK guidelines. The ADA have been released in 2009, where they use the plasma glucose cutoff of more than 13.9, and they do classify the DKA based on severity, based on pH, where a pH between 7.25 to 7.3 is considered mild, below 7 as severe DKA, and in between moderate. They highlight the use of positive urine ketones as a diagnostic criteria. However, there was no mention on the use of capillary ketones measurement. However, I think in an update in 2019, this has been highlighted on this guideline. And also they highlight the incidence of euglycemic or mild hyperglycemic DKA. On the other hand, UK guidelines have been released 2013. They use the cutoff blood glucose of more than 11, and they defined severe DKA based on pH below 7 and biocarb below 5. And they highlight actually, and they strongly recommend the use of capillary blood ketones for diagnosis and for the management of DKA. So basically on this finding, we could say that our patient is having euglycemia or mild hyperglycemic severe DKA. And therefore he was managed based on DKA protocol, and every DKA protocol will have a highlight on IV fluid management, electrolyte replacements, and insulin management. And also he has been started in broad spectrum antibiotic. So coming to the intravenous fluid, both guidelines, the American Diabetic Association and the UK guidelines, suggest the use of bolus fluid initially around 1 liter of normal saline, and then to maintain the fluid in the range of 250 to 500 ml per hour. However, the UK guideline recommend to continue normal saline throughout the management of DKA, while the ADA guideline recommend to switch to half normal saline when in a patient with normal or high corrected sodium. In both cases, when the blood glucose drop below certain level, then to add dextrose. In case of ADA guidelines, to add dextrose 5% when the blood glucose fall below 11, while in the UK guidelines to add dextrose 10% when the blood glucose falls below 14. In terms of electrolytes, both of them, of course, emphasize the importance of potassium replacement, since such patients have a total body potassium deficit. And ADA recommend the addition of 20 to 30 millimole of potassium in each liter of infusion when the potassium level is below 5.2, while the UK recommend adding 40 millimole when the potassium is below 5.5. And in both cases, when the potassium is below 3, you need to suspend insulin, replace potassium before recommencing insulin. The replacement of phosphorus and bicarbonate as a routine is not recommended in both guidelines. However, ADA guideline recommends slow administration of 100 ml of bicarb in cases of severe DKA when the pH is below 6.9, while the UK guideline does not recommend the use of bicarb in any patient with DKA. In terms of insulin, both of the guidelines recommend using fixed weight-based rate, while in addition, ADA recommend the possibility of using a bolus dose before initiating the fixed weight-based. And in terms of adjustment of intravenous insulin rate, it can be adjusted based on glucose drop by 3 to 4 millimole in the ADA per hour in the ADA guideline, while the UK guideline recommend increasing the insulin rate by 1 unit every hour in order to achieve either blood ketone reduction by at least 0.5 millimole every hour, or increase in bicarb above 3 hourly, or decrease in blood glucose more than 3 hourly. And the UK guidelines also recommend continuing patient basal insulin dose, usual one, or starting basal insulin dose of 0.25 to 0.3 units per kg. So this patient was started on DKA protocol. He received almost 5 liters of crystalloid fluid, but his pH remained the same. It remains below 7. So it was decided to give him bicarb, and actually he received almost 4 boluses of bicarb, or 3, and his pH remained static around 6.9. Within a few hours from his presentation, he developed respiratory distress and required assisted ventilation and intubated. So you can see here in this figure, this patient glucose in pink, and his bicarb in orange color, and in brown color is the pH. And you can see that despite dropping down his glucose, his bicarb and his pH remain static and low. He received almost 4 boluses of bicarb. He then was started on CRRT, and also after that, this was followed with 2 hemodialysis sessions, and barely we could just bring his pH above or near 7.2. So there is something going wrong, and later the family were able to come and bring his medication. And we could see that in his medication list, he was on canagliflozin 300 milligram, for which he has been on for the last 3 years when we know from him about this prospectively. Also, it was reported that he had uncontrolled diabetes and he refused to start insulin as per his primary physician recommendation. So at that time, in our hospital, we did not have a point of care inpatient ketone measurement. And I will give you just here in this table an overview of ketone measurement. You can either measure ketone from urine, which mostly used and available in most hospitals, or you could measure it in the plasma and serum, or you could measure it just capillary ketone as a point of care measurement. The advantage of the plasma ketone is that it measures the current plasma ketone concentration following allowing diagnostic certainty and subsequent management. It allows timely changes in the treatment. It is fast, immediate measurement. It has great sensitivity and specificity. And it measures the beta hydroxybutyrate, which is the predominant ketone in DKA. And also, one of the advantages that the wrapped ketone strips have a long shelf life. The disadvantage, of course, it is potentially painful because it is like the glucometer, so you will need to stick the patient frequently. It needs equipment and meter. It needs quality assurance, and it needs staff training, and it is relatively expensive. However, also, the readings would not be correlated with the serum hydroxybutyrate, beta hydroxybutyrate at ranges that are designed outside the studied range. And there is also interference with some substances. However, urine ketones reading are an average of urine ketone concentration since last void, so it may delay the management and may be negative at the beginning. The length of time of resolution of DKA may be overestimated using urine ketones, and the urine sample collected may be delayed due to dehydration, and it has lower sensitivity and specificity for DKA. And it only measures acetoacetic acid, not the beta hydroxybutyrate. And the ketone strips, urine 1, have a relatively short shelf life. And also the same, it has interference with vitamin C. However, it is advantage, it is basically painless. Reading can be read off the bottle, no quality assurance needed, no technical skills needed, and relatively it is cheap. So in our case, we use something else. We use the ketone freestyle optimum ketone meters that is used for our outpatient type 1 diabetes. And it is not indicated definitely for this. However, we thought maybe it will help us in this patient management. And we use this for ketone measurement and to titrate insulin infusion and escalating it both with dextrose and intravenous potassium, aiming for increasing ketosis clearance. And this is what happened. When we start to measure the ketone, at that point, you can see the green line is the insulin rate, the blue line is the glucose, and the red one is the ketone. So at the beginning, his insulin rate was less than 2 units per hour that maintained his glycemia to less than 10 millimole, but his ketones were very high. So you need that to increase the ketone or to increase the insulin rate, increase also the dextrose infusion, also increase the potassium KCl infusion through central line. We give him up to 80 millimole per liter. And then we can see the dramatic decrease in ketone measurement through the capillary or point of care capillary measurement. And in this figure, you can see here, we started to measure ketone. Then dramatically, we were able to increase his pH and bicarb. However, you can see intermittently here, there is a drop in pH. And the reason behind that is because when we increase his insulin, there is a drop in dextrose and potassium. And therefore, it was interrupted sometimes. So you need to make sure to give enough KCl infusion and dextrose in order to avoid hypoglycemia in such cases. Also, it was notable that despite being dehydrated, this patient actually have polyuria at the beginning and the first few days of a presentation. Now, coming to the criteria of resolution of DKA. Based on ADA, the resolution of DKA is defined when the blood glucose is below 11 plus any two of the following: bicarb above 15, pH above 7.3, and anion gap below 12. While UK guidelines define a resolution of DKA as pH above 7.3 and the blood ketone concentration below 0.6 millimole, and they do not advocate bicarb because of the hypercholoremic acidosis that is associated with a large volume of normal saline, and this will lead to delay in increase in bicarb. Further investigation, our patient showed that he has poorly controlled diabetes with hemoglobin A1C of 13.3. He had low C-peptide at the time presentation. His autoimmune antibodies were negative, and his respiratory viral panel was positive for adenovirus. So the case outcome, in addition to DKA protocol that he received a total of 3 sessions of intermittent hemodialysis. He received continuous renal replacement therapy with a dose of 30 ml per kg per hour. I don't understand this a lot. However, our nephrologist said this is very high dose, starting before first dialysis session and continued in between, and even after the last session, dialysis session, he required many bicarb boluses. It took almost 62 hours to correct his metabolic acidosis and close anion gap with all these modalities and with insulin rate titration based on capillary ketones. He was extubated in day 4 and basal bolus started on day 5. Despite resolution of DKA, his cutonemia above 0.6 was persistent till day 12 of hospitalization. During his hospital course, he developed provoked femoral line site deep venous thrombosis and pulmonary embolism that was managed with anticoagulation, and his total admission hospital course was 16 days. So basically, this case comes up with a few questions that we need to look for. First, is there an increased risk of DKA with SGLT2 use? And you can see that in 2015, the FDA issued a drug safety communication after a post-marketing report of 20 clinical cases requiring hospitalization between 2013 and 14 with the use of SGLT2 inhibitor. However, the clinical data around that was scarce. However, we know that most of these patients were type 2, and some of them actually, after the presentation with DKA, were reclassified as type 1. FDA also identified potential triggering factors like intercurrent illness, reduced food intake, reduced insulin doses, and history of alcohol intake. And therefore, also they highlight the importance that most of these cases were presenting without significant hyperglycemia. That's mean euglycemic ketoacidosis with blood glucose less than 13.9. And this could contribute to the delayed recognition and the treatment of such condition. Then many groups tried to look really for the risk of DKA after initiation of SGLT2 inhibitor. And in this study, they used a large claim database where they look for the DKA cases in a newly started patient on SGLT2 inhibitor, and they used the comparator as a DDB4 because DDB4 commonly used as a second line and it is not associated with DKA. And what they could find that within 180 days of initiation of SGLT2 inhibitor, it was associated approximately with twice the risk of DKA compared to DDB4. And the cases of DKA leading to hospitalization was, however, were infrequent, and the number of patients or the rate was almost ranging between 2.5 to 7.5 per 1,000 person year. And that the increased risk of DKA with SGLT2 inhibitor was among the factors to be considered at the time of prescribing and throughout therapy if the patient presents with any symptoms suggestive of DKA. Another group tried to look on the data from FDA adverse event reporting system. Between 2014 and 2016, they could find more than 2,300 cases of DKA reports in which SGLT2 inhibitor was listed among suspected or concomitant drug. And you can see among the years, there have been a dramatic increase in the number of such reported cases, especially in patients who are diagnosed with type 2 diabetes, where these drugs are used mainly. And as you can see that this incidence or this increase is among all types of DDB4 and mainly, among all types of SGLT2 inhibitors and mainly in type 2 diabetes, and mostly actually ended up with hospitalization. However, also other serious events have been reported, but luckily the death rates was still low in all these cases. And from their conclusion, they could calculate something called the proportional reporting ratio of DKA. So the proportional reporting ratio of DKA in reports including versus those not including SGLT2 inhibitor and having diabetes indication was around 7.9. And that was higher also for type 1. And that most patients who have SGLT2 inhibitor associated DKA, they don't have other concomitant conditions. And in going with detailed analysis, they were mostly women. And this is possibly attributed to the risk of a genital infection with such medication, which is more common in women. However, also they highlighted that there was a wide range of age reported and wide range of body weight reported, and the duration of treatment was also extremely variable from 1 day of initiation to more than 8 years. And also in this, they highlighted that this data bring pharmacovigilance action, but do not inform on the true risk in a clinical practice. And many people depends on the cardiovascular outcome trials. Initially, the empiric outcome did not show increased risk or non-significant increased risk of DKA among patients who are on the active arm versus placebo. However, Canvas program showed actually increased risk, though with a hazard ratio of 2.33, though it was not statistically significant. And in Credence also trial, there have been significant increase of DKA in active arm compared to placebo. Then Declare TIMI 58 trial showed a statistically significant increased risk of DKA with patients who are on DABA compared to placebo with 0.3% versus 0.1% and the hazard ratio of 2.1. So is there an increase? The answer simply yes, there is a small but significant risk of DKA associated with their use, and possibly maybe this risk is higher in real world. However, it is a small risk, still a small risk, I mean. Then the second question, is there a difference in DKA severity or characteristic between SGLT2 users versus non-users? And this question arises because DKA can be difficult to identify in patients with type 2 who are an SGLT2 inhibitor for two main reasons. First, these patients usually have undifferentiated symptoms. Their symptoms could be similar to the concurrent illness that they have, or to the post-operative symptoms or medication that are used post-operatively. And number two, that these patients could have lower than expected blood sugar. And this may explain the delay initiation of ketone testing. From Canvas program, you can see that they tried to describe these cases of DKA, which are around only 12 cases compared to patients who are on this medication without DKA, almost more than 17,000 cases. And what they could figure that patients with DKA who develop DKA while on Canvas, they have a higher, while on canagliflozin, they have a higher hemoglobin A1C, they have a lower BMI, and they have a lower GFR, and they have a longer duration of diabetes. Another study from Singapore tried to characterize the SGLT2 inhibitor associated DKA that have been reported as a adverse drug reaction. And they highlighted that the majority of these cases were presented or diagnosed within 180 days of initiation, and mostly in female, and mostly in patients who have long-standing type 2, or mostly patients have long-standing type 2 diabetes, and they have precipitating factors. And they also mentioned that there is an absolute number, or the absolute number of SGLT2 inhibitor associated DKA are expected to rise, as can be depicted from this graph. And you can see that the most precipitating factor was actually acute illness. Here in this table, you can see that the average hemoglobin A1C in these cases was around 10.2, and BMI was around 27.6. And as I said, they have longer diabetes duration, and they were mostly female. Another study from Korea tried to compare patients who have DKA related to SGLT2 inhibitor versus those who have DKA without using SGLT2 inhibitor. And this is, of course, only 15 patients compared to 508 patients. And they found that there is no difference in duration of diabetes, and there is no difference in BMI or baseline hemoglobin A1C, or even in severity of DKA based on pH. But of course, there was a difference in the glucose level at the time of presentation. And they found that patients who have DKA related to SGLT2 inhibitor actually have a longer ICU stay compared to patients who are non-user, 4 days compared to 2 days. This is another systemic review where they tried to collect all cases reported to happen perioperatively with DKA and SGLT2 use. And they found that around 47 reported cases with a hemoglobin A1C of 8.3. Mostly were, of course, type 2 diabetes. However, most of these patients have bariatric surgery. And the only difference between these euglycemic or hyperglycemic DKA among these patients, majority of them, 42 out of 47, are euglycemic DKA. And they tried to characterize or collect the time of a presentation, time to presentation of DKA, and it was widely ranged from 5 hours to 6 weeks in bariatric cases, and on average 3 to 10 days. There have been variable handling of SGLT2 inhibitors in such cases. Some of them stopped 1 day before surgery, some of them 2 days, some of them 3 days, and even the handle of preoperative insulin management was variable, and despite that, all these patients have been reported to develop DKA. The other thing that to be mentioned in this case series or systemic review, that the time to recovery was ranging from 8 hours to 5 days. And you can see when they look for the precipitating factor that the majority of them were diet modification with very low calorie diet pre-operatively and post-operatively, as well as post-operatively. And do remember that most of them were a bariatric patient. Recently, there have been a case series of 8 patients from multi-center that have been reported to develop DKA in preparation for colonoscopy. And all these patients, they took their SGLT2 inhibitor the day before a procedure. And this highlights that bowel preparation and dehydration could predispose such patients to DKA even when they are going under minor procedure. However, we learn more from cases. Recently, there have been a few cases reported that highlight something unique for SGLT2 inhibitor, which is prolonged diabetic ketoacidosis. And I would say that these are few cases. Most of the cases are managed the same way. However, there have been few cases reported where they have prolonged DKA, like our patient. And we tried here to put in this table our case with all the cases or that have reported prolonged recovery of DKA. And you can see that in most cases, multiple modality of treatment have been used, including dialysis and CRRT. And that many of these cases, ranging recovery or resolution of DKA and resolution of diabetic ketoacidosis range from 48 hours to 1 week. Also, this case highlights the effect of obesity on DKA outcome, and I could find only 2 poster abstracts where they highlight from database whether a morbid obesity can affect the DKA. And they found that there is increased odds ratio for mortality with the morbid obesity. And also in this second poster, they found also increased length of stay, which was statistically significant. However, I'm not sure if it is really clinically significant, 3.79 days versus 3.14, but also associated with a higher hospitalization cost and a higher mortality rate. So what are the precipitating factors identified on these cases with SGLT2 inhibitor-associated DKA? Mainly it was surgical stress with limited perioperative withholding of SGLT2 inhibitor, insufficient pre- and post-operative or reduced dose of insulin, reduced perioperative oral intake, and low-carb intake, concurrent illness, infection, dehydration, alcohol intake, and recent initiation of SGLT2 inhibitor. So the answer for the second question, yes, there is a slight difference. SGLT2 associated DKA may present with atypical signs and symptoms. Usually there are a precipitating factor, and some cases may require more than usual insulin doses in order to be able to clear ketosis. So what is the potential mechanism of SGLT2 associated DKA? Actually, what happened with SGLT2 inhibitor is that it will make an imbalance between the glucagon to insulin ratio, where there will be more glucagon and lower insulin. And therefore, this will increase lipolysis, gluconeogenesis, and ketogenesis. Glucagon will lead to the formation or induce the formation of ketones, and also it will stimulate the hormone-sensitive lipase in the fatty tissue to degrade triglycerides and produce fatty acids. So glucagon promote basically the availability of free fatty acids and promote the ketones production. And this is caused by the imbalance in the glucagon level to insulin level in SGLT2 inhibitor use. And this happens mostly when there are provoking factors, as I mentioned before. So how to reduce the risk of DKA in people with type 2 taking SGLT2 inhibitor? And this year, FDA has a safety alert as well and recommendation that canagliflozin, dapagliflozin, and IMBA to be held for at least 3 days before any scheduled non-urgent surgery, and etroglyphosine to be held at least for 4 days, and this depends on the half-lives of this medication. However, actually ACE was ahead on that matter, and it published its recommendation in 2016, where it recommended stopping SGLT2 inhibitor at least 24 hours prior to elective surgery or invasive procedure or any anticipated stressful physical activity, including running marathon. And also they recommend avoid stopping insulin or decrease the dose excessively. And also they were against routine measurement of urine ketone as it may be misleading. And also they recommend that patient taking SGLT2 inhibitor should avoid excessive alcohol intake and very low carb or ketogenic diet. EMA also in 2016, the European Medicine Agency highlighted this risk of DKA with SGLT2 inhibitor, and they also recommend stopping SGLT2 inhibitor temporarily in patients undergoing major surgical procedure or hospitalization due to acute serious medical illness, and that the treatment may be restarted once the patient condition has stabilized. Also, they emphasize to exercise caution in patients with risk factor for ketoacidosis and inform patients about these factors, including low reserve insulin secreting cells, sudden reduction in insulin dose, or increased requirement for insulin, like due to illness, surgery or alcohol abuse, and conditions that restrict food intake or can lead to severe dehydration. However, they did not highlight exactly how many days we have to hold this medication. I think more initiatives have been taken from the Australian Diabetic Society, where they come up with a very specific recommendation in order to prevent this complication. And they suggest that SGLT2 inhibitor has to be stopped at least 3 days preoperatively, 2 days prior to surgery and 1 day on the day of the surgery, or in other physical stressful situation. Also, they consider postponing non-urgent surgery if SGLT2 inhibitor have not been ceased prior to surgery and the blood ketone is above 0.6 millimole per liter or hemoglobin A1C above 9, as there is these are indicator of insulin insufficiency and a higher risk of DKA. Also, they had guidance on how to check the blood glucose and ketones in the preoperative period and what to do with that. Also, they recommend restarting SGLT2 inhibitors when the patient can eat and able to eat and drink and close to discharge, which is usually 3 to 5 days post-surgery. And they also recommend that patients who have a day surgery or procedure should only recommence SGLT2 inhibitor of a full oral intake. Recently, there has been a review article, actually it's from the Australian group.
Sorry for the interruption. Can you start ending?
Yeah,
Yeah,
I have just 2 slides more. So this can be accessed and I will not go through it because it is similar to the Australian Society guideline. And therefore we answer for the question 4, yes, we can prevent it by following the previously mentioned recommendation. In terms of management, usually most of these patients can be managed with the local DKA protocol. However, be aware that sometimes SGLT2 inhibitor may have lower than expected PGL, and in some cases you need more insulin in order to reverse insulin-glucagon ratio away from ketogenic state, and therefore you will need more dextrose and KCL replacement. And probably, maybe in such cases, ketone-guided insulin titration will be better than glucose-guided insulin titration. Also, be aware of intravenous hydration to combat osmotic diuresis. The summary already has been highlighted through the presentation that there is a small risk, and with atypical signs, precipitating factors, it can be prevented, and it may need multimodality treatment. Only questions that may remain. and is the safety of initiating SGLT2 inhibitor during hospitalization, especially patient with heart failure, fasting prolonged hours, more than 20 hours, let's say, and SGLT2 inhibitor use. What is the ideal really duration of holding the drug prior to procedure or surgery to prevent DKA? All these questions do not have a clear answer yet. Thank you for your listening, and I will hand the mic back to Dr. Asma. Thank you very much.
Thank you, Dr. Raya, for the interesting case. I'm sure that we're going to discuss it more in the Q&A session. And I would like to thank our attendees for tonight. We're having a great number of attendees, more than 620. Thank you for staying with us tonight. If you're having any question, please a reminder for everyone to put your question or write it down in the chat box, and will be answered during the Q&A session. Without any further delay, we'll move to our third speaker for tonight, Dr. Noura Hassani. She's the Chief of Pediatric Endocrinology and Diabetes Division at Tuam Hospital, Adjunct Assistant Professor at College of Medicine and Health Sciences, UAE University. And Dr. Al-Hassani's research interests include type 1 diabetes and growth disorder. Dr. Al-Hassani will talk today about interpretation of insulin pump download. Dr. Noura, feel free to unmute yourself and start your presentation.
Thank you, Dr. Asma, for your kind introduction. Good evening, everybody. My talk today is going to be about interpretation insulin pump download. It is a skill that definitely all of us need during our routine daily practice. To start with, there is no related disclosure. Our main objective is actually just to answer three main questions. What are the insulin pump we are talking about here? Why we need to know how to do this interpretation, and how we can do the interpretation of insulin pump download. To start with, what is the insulin pump? Insulin pump is the continuous subcutaneous insulin infusion. It is the most common advancement in diabetes management technology. It aims mostly to achieve the target glycemic control, to reduce the episodes of hypoglycemia, and to reduce the chronic complications of type 1 diabetes. And this is all has been confirmed by multiple studies in children and in adults. How does the insulin pump looks like? It is a small device, as you can see. It is actually smaller than your smart phone. Contains a display screen with an insulin reservoir where the short-acting insulin is used and is being pumped on an hourly basis to the patient mostly through tubing and through the cannula. Few are done by a direct patch to the skin. This pump, nowadays, most of the pumps are actually connected with what we call it a sensor, continuous glucose monitoring, which measure blood sugar all the time, as you can see here, and it sends directly the readings to the screen of the pump. So in each clinic visits, what is happening is that patient is bringing his own insulin pump. We do the download, it's done through a Bluetooth or using USB. What are the common used pump? There are different pumps available. Definitely here, I'm not promoting for any, but this is just to show you how many different pumps is available and how many, each one with definitely different features, different cost. It is very important for you to know which pump you are commonly used in your own center. For example, in Sahha and in our own hospital, it is mostly two, the Accu-Check and Medtronic. More than 90% of our patients are on Medtronic. Currently, we do have the FIO and the 640G. We got recently the approval of 780. That's why my talk about the download is mainly related to this pump. So what are the indications for using the insulin pump? Pediatric indications based on the ISPAT 2018, they did mention here it should be considered for patients or children with recurrent severe hypoglycemia, wide fluctuations in blood glucose level regardless hemoglobin A1C level, suboptimal diabetes control, microvascular complications and or risk factors for the macrovascular complications, good metabolic control, but insulin regimen is compromising the lifestyle. It is considered to be as well beneficial in young children, infants, and neonates, and those with Down phenomenon, children with needle phobia, pregnant adolescent, ketosis-prone individuals, and in competitive athletes. Okay, what about the adults? In adults, as per ADA, pump should be considered an option for adults, children, and adolescents with type 1 diabetes who are able to safe manage the device. So what are the pros and cons of insulin pump? Each technology has its benefit and its side effects. The most advantage of insulin pump, definitely improving the blood glucose control, to the insulin availability all the time whenever it is needed. Use multiple basal rates during the day and during the night. Use temporary basal rate during, for example, acute illness, during exercise, during fasting Ramadan, or menses in girls. The ease of administration of multiple boluses, reduction of hypoglycemia, flexibility, control the post-meal blood sugar through CGM, and it's adjusting through with the exercise and with the travel. In other hand, the disadvantages are that the patient, they need to remember to give the insulin pump with the food intake. There is higher risk of ketonuria, ketoacidosis, as it is usually using a short-acting insulin. Psychological factors, the expense, definitely, weight gain, skin infections, unavailability of the insulin, and instability, infusion site infections or complaints, physical or logistic considerations. So what are the basic guidelines whenever you would like to start patient on a pump? There are specific points you need to start with and to use it whenever you are starting patient on a pump. The first of all is definitely what is the patient currently taking and how much total daily dose. Usually you could reduce it by 10% or further even by 20% if there is no much of risk of hypoglycemia. Or the other way, if there's more of hypoglycemia, you reduce it by 20% and use this total amount of insulin for your initial setting of the pump. Second point is the proportion of the basal versus bolus insulin delivery. So usually it is 50-50, while in younger age it can go to 40 to 60 or even 30 to 70. Determination basal rates. For example, if you are deciding to go with 50-50, so half of the total insulin dose, you need to divide it over the 24 hour to calculate how much unit per hour basal rate should be there. Notice that sometimes you need to change this during the day or during the night based on the patient condition. Usually pubertal children, they require higher rate early morning, while the younger age, they require higher during late evening and early morning. Determination correction factors or insulin sensitivity factor. So if the patient already is applying this sliding scale and he has his own sensitivity factor, he uses it, you can start with, or you can calculate it by using, for example, formula 1700 or 1800 over the total insulin dose. Determination insulin to the carb ratio, the same. If he's already started and instead of giving fixed doses, he's using the carb ratio, then you can apply the carb ratio directly, or you calculate it by using 500 over the total insulin dose. And finally, there is definitely a frequent blood glucose check, especially in the beginning. They need to understand they need more frequent blood glucose monitoring to decide how it is going on with them. Pre-meals, 2 hours, post-meal, bedtime, 2 a.m. is definitely needed, and better definitely if there is a continuous glucose monitoring as well. So our next question was why? Why we need to know about this, the interpretation and the download. Simply first thing, because there is an much increased use of the pump worldwide. There is more than 1 million people worldwide use an insulin pump for diabetes management, including nearly 400,000 patients with type 1 in US. In a study looking at 96,500 patients with type 1 treated in 432 diabetes centers in Germany and Australia, they found that the mean age was around 18 years. Their management was 34.5% of them were treated with insulin pump therapy. And they found that the pump therapy was increased from 1% in 1995 to 53 in 2017. The highest risk of using the pump was in the youngest patients, preschool age. What are the other causes here? Digital technology has enhanced diabetes care. As you know, diabetes are all concentrated on data, carb ratio, sensitivity factors, blood glucose readings, hemoglobin A1C level. So the digital technology, it enhanced by the diabetes care by improving the collecting and analysis of those data for better outcome. Other point is it became an important part of a connected health service. This by this pump and the download, it allowed direct supervision and direct data sharing with the patient, the parents, teacher at the school, whoever the healthcare provider, definitely diabetic educator. So we are part of this. So that's why we need to understand this much more and to be able to improve it again, improve the care itself. And the last point, definitely to save the clinic visit time. I believe everybody is suffering as we do because of no much time to give for a diabetic child, for example, during the clinic visit. So to know how to do the download, where to look at the information exactly, it will save definitely much of our time. So now, most important, how to do the interpretation. So whenever I'm asking for the download of a pump, I'm gonna receive either hard copy or soft copy of around 20 to 27 pages. So it is very important, again, to know what I am looking at. Whenever the patient is on a pump, very important information I need to collect is or are the average blood sugar, the hyperglycemia, hypoglycemia, the time, if there's a specific time for hyper or hypo, for example, about the treatment, the total insulin intake, the basal to boluses ratio, how much he is giving boluses, and so on. So download, in general, it includes a specific, you need to know that it includes a specific reports. It's called the dashboard episode summary report, adherence report, sensor and meter overview, logbook report, device setting report, and daily detail report. We'll go over each one of them, but definitely you need to understand that this is, once ever you see this report and read it well, definitely very important point is to discuss it with the patient. So you can understand why he has this hyper and why he had that hypo at that time or so on. Other point, try your best to concentrate on creating one target on each visit for change and monitor the compliance. So the dashboard report, it's more of a summary in a graph and in numbers, looking for average blood sugar. If the patient is wearing a sensor, you will see this line. So it's giving more of the average blood sugar in a specific time, for example, over the last 2 weeks or over the last month, and giving a different time during the main meals, breakfast, lunch, and dinner. It give us here as well, then as a number, the average blood sugar, estimated hemoglobin A1C from the pump readings entered in the pump itself. Again, the total insulin intake all over the day, as well as the basal and boluses taken. Definitely, you can have a good idea where's most of hypers, or if there is hypo, for example, and so on. There is the episode summary report looking mainly for the hypo and hyperglycemic events. in more of details, how many attacks, what could be rational or causes behind it. There is the adherence report. It indicates more of patient work on the pump, his adherence, work on entering the meals or carbs, entering blood sugar readings, the action he's doing, any overriding, changing the infusion sets, which should be every 3 days. For example, if you're using a pump with which is suspended before or on low, you can see it here, suspended the duration, how many minutes or hours has been suspended on that day or collectively during that period. Sensor and meter overview. So again, the same, giving you a general idea of all over how is the blood sugar going on, where is the mostly the hyper, the hypos, pre and post main meals. Another view with the blood sugar readings entered without the sensor reading. The same informations, average blood sugar, the how much is hyper, hypo, total insulin, and very important, the percentage, how much basal and how much polysis, for example, is it 50-50 or less? Another view for the sensor and meter is day by day in more graph, the same information, exactly blood sugar readings, carb entering, how much insulin has been given each daily on daily basis. Logbook report, the same again information, but in a logbook form where you can easily, for example, looking at all daily on daily basis, morning time, how is it? Is it more of hyper? Is it more of hypo? The same for lunch and dinner. What is the difference between the day and night and so on? Device setting. Mostly we are looking here on the basal amount, total basal amount, how much the rate over the day and the night. If there is a temporary basal being used, different basal at different times will be there as well. The sensitivity factor, the carb ratio patient is on. And there is also as well definitely the daily detail report where again the same informations but day by day, looking exactly at each reading, what was the action, how much insulin has been given, and how much carb was taken, if taken or not. Okay, so let's go to the cases. We'll start with this one. The first one is almost 14 years old female. She's known type 1 diabetes since 2013. Unfortunately, she is uncontrolled, non-compliant. Last hemoglobin A1C is 9.8, which is almost the same as the previous one. The problem with her is she is keep eating or snacking frequently, but really she is not really entering. So you can see the overview here. I will give you seconds just to have a look to her download. So as you can see, this is the average blood glucose readings. She's wearing a sensor. So you can see that the most readings actually from around 10 a.m. to 10 p.m. And this is the time she is wake up, while it is slightly less over the night. Average blood sugar is 240. If you need more information, we can move to the other reports. So here you can see she's entering for food around 2 to 3 times. And as I was saying, she is snacking. She's saying she's snacking in between, but the problem, she is not entering. The correction, the same, around 2 to 3 times do actions for blood glucose readings. Again, the average is 240. 70% of the readings were high. Total insulin is 70 with 65% basal. So most of her insulin actually running is a basal. So here, the logbook, the same. More hyperglycemia all the time, specifically more during the main meals and even actually in between. But there is no concern, much concern about hypoglycemia. So a question for you, audience. What action you recommend based on this download you saw? Do you suggest to increase the basal rate? increase sensitivity factor or carb ratio to give less doses or boluses, decrease the sensitivity or carb to give more of boluses, or behavioral lifestyle changes increase the compliance and entering into the pump. You have at least 15 seconds to answer. Notice there is no right or wrong answers here, definitely. This is more of action you think you have based on what problem list you read from the download. So most of our audience, 67%, they suggest the behavioral lifestyle changes, while 19% they will increase the basal rate, 9% they will increase the sensitivity or carb ratio. I agree with the majority. Yes, behavioral and lifestyle changes is the priority here. Actually, the problem, if you can see here, it's not really the setting per se, but the patient action or compliance adherence to the pump. So if they are really, or if she is really compliant and keep entering each carb she is taking, she will give more boluses. So the boluses will be higher than the basal in general. So control the diet, control the time of the diet, give the insulin as it should be for the meal and for the sliding scale at the right time. Then we can review it later after a week or so. If still with this better compliance, still there is hyper, yes, you might consider increase, for example, the carb or decrease actually the carb or the sensitivity factor to give more of boluses. Let's see the second case. Second case, actually, the brother of the first one. He's at 12 years old, diagnosed in 2019, which is around 6 years post his sister diagnosis, but he's doing worse. His hemoglobin A1C was 14, last one 10%. He has issue of a morbidity, morbid obesity. And if you can see, again, this is the overview download. If you notice, it's almost the same as his sister, isn't it? So mostly there is the hyper from the morning till he start to sleep, although he's continue here mostly to the early morning. The same average blood sugar is been increasing. It is in 200s. Looking for his adherence, he's doing better than the sister. He's entering 4 or 5 times and the correction as well. But still, most of the readings being high. There's no much drop in blood glucose post the corrections. And the same, his basal is mostly high, 70% of his insulin is basal. Here is the readings day by day, and it's showing the same, most of the readings being high. For this one, it is definitely very important. The main point here is that to understand that our diabetic, they might be a poor model for their siblings or for their peers. So very important, the proper education. They need to teach each other the right actions, the right management and care of the pump. For the brother, the same. The recommendation was for more of a lifestyle improving, plus increasing of his sensitivity and carb as he is requiring that. So moving to the third case, I believe this is before the last one. So 10 years old male, type 1, diagnosed since 2012. Last hemoglobin A1C is 8.2. And here is the overview download. Just seconds for you to see it. So if you could recognize, there is mostly hyper. If you notice, like a peak hyper during mostly the main meals, beside the early morning. There is no much concern of hypo. More details. She is entering for food 6, 7 times, which is very good. For correction, 3, sometimes 9 times. The mother was saying she is keep entering more during the night, more of correction because she keeps snacking late night and early morning. She sleep late. While for the main meals, she's afraid of getting hypo, so she's not giving the insulin at the time of the meal. She used to give it post the meal, once she finished her meal. And again, the average is 200. Basal is 62%. And here is the logbook, where is hyper mostly during early morning, even with frequent corrections and policies during the night, as well as during the lunch and dinner. So a question again for you audience: what action you recommend with this patient? Is it to increase the basal rate, to decrease sensitivity or the carb ratio to give more of insulin, behavioral or lifestyle changes, and finally, is it all of above? We'll give you 15 seconds to answer, please. Okay, so again, most of our audience, they choose the all of above. I agree again with you. Although the patient basal is already high, but she want to increase the basal, for example, here, as you can see, during the night. So I'm suggesting to increase the basal during the night to avoid this frequent snacking, frequent policies, requirement of policies during the night. We need, before adjust the carb and sensitivity ratio, we need to change her behavior. We need to ask her to give it definitely at time of a meal instead of later on, to avoid this peak of blood hyperglycemia. And probably she is requiring to increase as well her policies through decreasing the sensitivity factor. Okay, our last case is a 7-year-old female, type 1, diagnosed 1 year ago, in October 2019. At time of diagnosis, she was 9.6, but later on it becomes 6.8, recently 7. And here is the overview of her download. Have a second, just seconds to have a look. The problem with the mother of this patient, and which is strange, and it is really uncommon to see in our clinics, she's a type of who preferring more of hypoglycemia, prefer to see a low readings, much better than even upper normal readings. You know, most of our parents prefer the other way, to see high readings, avoid the hypos. They get scared from hypos more than hyper. So for her, she used to give more corrections when it is needed. And recently, actually, even she started to play with the basal. She started to increase the basal rate whenever she see more of hyper and she think it is not related to food. So she increased the basal. And this is what she did recently over this time here. Early morning, she increased it because she saw a more of hyper during early morning time. And if you can see here, yes, there's some hyper during main meals, but more of hypos different time, but mostly post the meal and here early morning time. More details on the download. Again, she's entering 5 times most of the time. She's entering for 1 to 2 times because she starts to see lower readings, which is not really requiring much of corrections. And here is the average readings in general. Still, it's going down, obvious post corrections. Her policies is 70%, while the basal is around 30%. And here is day by day through the logbook. You see much of this a suspend of the pump, which is suspended before low or on low. And this is noticed more over the night, beside again post meal. So what is your action for this patient based on this download? Are you going to decrease the basal rate, which is already low? You need to increase the sensitivity factor and carb to give less boluses, behavioral lifestyle changes, or all of above. Again, you have 15 seconds to answer. So our answer again, 60%, all of above. I will say yes. Although the basal, let's close this one. So for this patient, although the basal is already low, it is to be in safe side. We need to reduce the basal here in this time or during this period. We need to reduce the carb as the mother keep entering the carb, and this is the problem more than the sensitivity factor. So increase the carb amount, so to give less for the food is definitely required. And very important, more than this and that, is mother education. She need to understand what is the target for her age. We would like to avoid hypo as much as we would like to avoid the hyper. So for the time, let us conclude. Our main objective here was regarding the insulin pump, which is a part of the digital technology involved in diabetes care. Its use has been increasing worldwide. Multiple benefits are there of a right interpretation of the insulin pump. Looking at the main report while interpreting the download is very important. And finally, try your best to work on a one target in a time or in each visit. Thank you very much for your listening. And I'm handing back the mic to Dr. Asma. Thank you.
Thank you, Dr. Noura. Interpretation of the insulin pump has been always something difficult for many physicians. At least you give us highlights how to interpret the pump. Again, thank you for our great attendees. If you're having any questions about Dr. Noura's session, just put your question in the chat box and will be answered shortly in the Q&A session. Without any further delay, we're moving to our academic session for tonight. Mr. Bakhit Bishtawi is a specialist librarian at Medical Library, Dubai Health Authority. His team is responsible for managing and developing all the library electronic collections, services, and training. He's the editorial administrator at the editorial office at Dubai Medical Journal. Mr. Bakhit will talk today about how to write a paper in 30 minutes with Google Documents. Mr. Bakhit, mic is yours. Feel free to unmute yourself and share your slides.
Okay, thank you, Dr. Asma. Give me a minute to share my screen. Hello, everyone. I hope that you can hear my voice and see my screen. My name is Bakhit Bishtawi. I am the specialist librarian in Dubai Health Authority Medical Library. At the same time, I am the editorial administrator for Dubai Medical Journal. My session today is on writing your research manuscript in 30 minutes. We will have a session at the last maybe 10 or 15 minutes, and we will together write a paper. Meanwhile, I need around 10 of you, 10 of the 600, I think something attendees, around 10 people. Please share with me on the chat or in the question and answer your name, workplace, and Gmail, and I will try with the help of one of the library coordinators to share with you the research component and make a practical session on how to write a paper using Google document. The learning objectives of this session actually is to understand at least the manuscript research components, as well to experience a collaborative writing session using Google documents. If everything is going fine, 30 minutes or 30 days, is it possible to write a paper with the availability of technology, professional application? Is that possible? Yes, you can start from today with a group of authors, colleagues, and with the help of the open access applications like Google Documents, where the location no matter and from anywhere at any time, an author from Dubai, a second author from Riyadh, Saudi Arabia, one from UK, one from the state, group of authors on one shared document. You can start from today, prepare your writing to publish a manuscript, to publish your research. I am sure some of you, the 636 attendees, experienced or know this and have an experience on using Google Documents to write in a collaborative way. Whatever the type of the article you are going to write, a review article, original research, a case report, a case series, a systematic review, meta-analysis, etc., an editorial, a commentary, opinion. What's the common in all of the above? And I can assure for you that the article or the research components is common in all of the article types you might think of. The title, the abstract, the introduction, methods, results, discussion, conclusion statements, and the references. What else is coming will come as a subheading. You might go under methods, then you study design, etc. For the results, data analysis. So the else will come as subheadings, but this is the research components. Imagine that you are 4 authors. So from the beginning, sit down and said that, okay, I will write the abstract, you will write the discussion, you will write the methods, and so on. So by the research, by dividing the research components among you authors, 2, 3, 10, more or less, using Google Documents, you will be able to collaborate and finish your writing in a quick time, a day, a month, more or less, but at the same time, with the help of technology, working on one document. Imagine if everyone is working on a separate file, and at the end you want to merge all these files together. It's not easy, but working on one document, wow. The title, usually you will see in the title of the paper, and you will see, for example, the authors and the affiliation. I can assure for you many, or maybe all the journals, this is how they design, how they format the title and the authors and the affiliation. It's easy to do this using Google Documents in a collaborative way. And the second component, the abstract, and usually you should write the abstract when you finish writing the below all the components, the introduction, the objectives, methods, results, discussion, conclusion. Just 2 or 3 lines from each component, you will have a very nice, constructive, informative abstract. For example, one of the authors is waiting for the rest of authors to finish the work, then just he or she will read those components and make a summary, and you will have a very nice abstract. The introduction, the literature review, the history, the background, with the citation, it's very easy to do it using Google Documents and using a reference manager like RefWorks, like ProCite, like EndNote. At the same time, you can collect the references and save them in a reference manager, link yourself to the Google Documents, and you can start writing. At the same time, while writing, typing, other authors can see at a real time, or maybe later they can check and see what you did in your part, the introduction. And when it comes to the methods, the inclusions, the instruments, variables, study design, whatever, you can write it here, type it here, while other authors are busy with other components. Then you will come to the results, to the finding, to the analysis. It's very much easy to bring all the results together here in one Google Documents and format it for other authors in the group to see what you are doing. They can, by the way, edit, they can modify, they can change, they can suggest at the same time while you are finishing your part as contribution. By the way, in authorship, we always, as journals, ask for author contributions, what the first author did, what the second author did, and so on. So here, for example, in Google Documents, this can be easily touched and known that the results is done by ABC author, and so on. And when it comes to the discussion, the evaluating, the interpreting the results, it's easy while using or while working on one document. And if this is your component, your path as an author, you can easily start writing the discussion after, for example, other authors finished the results or the methods, the introduction, etc., etc. And the last important part is the conclusion. You will easily here conclude and recommend what you found in that study, in that research, in that paper. For example, after the authors finished the first 6 components, maybe somebody will call you or remind you, hey, it's your time now. Go and read everything above and make the conclusion, and later on we will revise it together. And an important part, the statements part, the acknowledgement, if you want to say thank you for somebody, the ethical statement. This is very important, by the way, in writing, to prepare the ethical statement if it is needed, especially when there is a human subjects in that research. And the disclosure statement, you can easily say, for example, authors have no potential conflicts, and the funding source, no funding source, or maybe if there is funding, you can easily write it here. Author contributions. Imagine while you are writing, other authors can help, can read, can see, can suggest. So in this environment of open access Google document, it's easy for everyone to contribute, to add, to modify, to suggest. And at the end, it's easy to write the author contributions, what exactly each author did, or some people say it all authors contributed easily. Then the references, while you are connecting the your Google Documents and the reference manager, it's easy to do citation and references at the same time. And this is an example. What's Google Documents? Simply, it's an online word processor application, allows you to create, format documents while collaborating with other colleagues in real time, while collaborating with other authors in real time. Exactly, it looks like any Microsoft Office word processor we usually, for example, use. And this is the URL of documents.google.com. All what you need is a Gmail Gmail account, and other authors, they should have also the Gmail account. You can see here in the toolbar formatting, you can select the text, you can insert image, you can insert table, tools, add on to link yourself with a reference manager or whatever. And here you can use this share button to share with those people to collaborate with you. Writing with Google document steps, go to documents.google.com, log in using your Gmail, create a new document, or by the way, you can upload already one, share the work with us, with others, assign the level of sharing, review, comment, or editing, means they can do everything. And for citation and references, link your reference manager to Google Documents. You can read there in the help messages in your reference manager and Google Documents how you can link the two applications together and do the citation and references. We will start writing a paper together now as an exercise. This is just a dummy one, by the way. I just imagine it like this. Screening for COVID-19 asymptomatic patients with diabetes. To write a paper together. I think some of you already shared their Gmail and workplace with me, and I will send, by the way, in 2-3 minutes to those people whom shared with me their Gmail, the component part they will be in, and just copy, paste the text. Again, this is a dummy manuscript. I will stop my screen sharing for 1 or 2 minutes only, then come back to you. I'm not sure it's not stopping. Anyway, let me go to the share. Yeah, thank you. Then I will try to find some of Yeah, thank you. I have a lot of emails, but I will assure for you that all will be with totally privacy, and I will not use them for any thing rather than this session. Give me 1 minute more. I will share my screen again. I just want to take some of these emails and try to prepare for the sharing. I think some of you already get an sharing email from me, from bishtawi@gmail.com. While we are waiting for the share with me, I will go back to my session, and here is the Google document. 1 more minute. Let me arrange my screens. Thanks for the technology nowadays. Okay, this is Google Documents, and here is a dummy manuscript. Those people who received from me a shared email, please check your Gmail. Not all of you, because I received plenty. Thank you. I think we will select randomly around maybe 10 of you. For me, I will start working on the introduction while I'm waiting for others. I think here I have 2 now already linked to my Google document account to this document. For me, I will bring my part, the introduction. Again, remember that we just copy pasted from some places with all respect to authors. Yeah, this is my part. I will start my reference manager, and I will let you see how to manage the citation in front of you. Again, I prepared this before. I have some files, some references already saved there. If I want to, for example, cite here in this place, okay, what I need is to go and cite this reference. Okay, you can see now, wow, nice. I got one reference cited. If I want to cite here, again, I will select the reference, then I will cite here. I can see somebody is working on the acknowledgement, thank you. Somebody else might start working on their parts. Still, we have time. I think we have 15 minutes. So let me go and select another reference to cite. Now I have 3 references cited. If I will scroll down, you see how nice the references are coming at the bottom of the document. Wow, really amazing. I hope that some of you already received. I think, yeah, there is somebody working here. I don't know who is this author. And for me, I will stop moving the screen, waiting for anyone who received the shared email from me to try copy paste his or her part somewhere here in the by the way, you can see my hands up. I am not moving anything. The screen is moved by another author. I have in my work many examples. People were able to manage their work, their manuscript, and I have positive feedback about using Google Documents in a collaborative way of writing, especially nowadays with COVID times and social distances. It's very much easy for a group of authors to start writing and using this technology. I advise, before you are doing the work, make 1 or 2 sessions together, just using dummy writing, and see how it will go. I can see the statement is done. Now I'm waiting for others. Is there any problem with the I hope those who received that email can share now and copy paste the parts they received and just put it here, so as we will end up with a nice dummy manuscript. Yeah, I can see somebody came to the methods maybe. let me see the question and answers. If there is any, please, the steps, is it clear? I understand, yeah. There should be more explanation, Rania, I understand. You cannot see the screen? I think Marwa cannot see the screen, but what about others?
It's clear, Bakhit, it's clear.
Yeah, thank you very much. Yeah. Okay, we will give 2 minutes more to allow some of those who received, yeah. I think those who received Nayef, Zainab, Aisha, Iman, Amna, Safiya, check your Gmail to find the part if you want to share and just copy paste what you get here. Anyway, I'm not sure. I think this session is recorded and live in YouTube. It's easy for all later to come back and see the whole slides. Anyway, at the end, when everything is finished, it's easy to go to download the whole dummy manuscript as a Word document, or even you can download it as a PDF file. You can see it now, it's downloaded, and you will get a very nice document, okay, written quickly by a group of authors. You can send it to a journal or anywhere you want. But again, as I mentioned, the good thing in this work is all the authors are working on one file. No need to merge files or make anything. Everything is on real time. From my side, I am done. Thank you very much all, and here is the 2 references for later. Thank you, and the mic back to Asma. Thank you.
Thank you, Dr. Bakhit, for the very good presentation about how to write the paper. And I think we need such topics more and more as a clinician. So we'll start our Q&A session. I invite Dr. Noura, Dr. Badur, and Dr. Raya. Please unmute yourself and we'll start our Q&A session. We'll start with the questions to Dr. Badur. There are a couple of questions to Dr. Badur about diabetes in elderly. So the first question is about the depression and diabetes, and if there is the antidepressant can decrease hemoglobin A1C use in the patient.
Okay. That's an excellent question, in fact. Now, depression is a very essential component to be assessed in diabetes in our daily clinic, but we tend to forget it because of the rush of the clinic. Now, missing diagnosing depression in diabetic patients lead to poor glycemic control. So in indirect way, treating the depression not the medication per se, but treating the depression leads the patient to better control his blood sugar at home. So yes, treating depression does improve the improve the glycemic control in patients. That's true.
Second question is about the use of SGLT2 inhibitors and LGP in elderly patients.
Yeah, so the first line of treatment in diabetes, this is well known, established, that's the metformin, unless it's untolerated or contraindication. Now the Endo Society and the other guidelines, yes, they do promote to use a medication with the positive cardiovascular outcomes like the GLP and the SGLTs in the elderly who have very frequently to have some element of atherosclerotic cardiovascular disease or depressed ejection fraction, plus their efficacy in blood sugar control, in addition to less chance of inducing hypoglycemia. That is one of the essential components when we treat elderly.
And there are another question about do you recommend single or dual oral hypoglycemic agent in elderly patients?
Okay, so that's an interesting question. Now, there are two committees, the American Association of Clinical Endocrinologists, they recommend a dual agent when the HbA1c 7.5 and above, and a dual or triple agent when the HbA1c 9% and above. On the other hand, the American Diabetes Association, no, they prefer to start monotherapy unless the patient is having HbA1c above 9. And but to bear in mind that above 9, if patients having active hyperglycemic symptoms, then insulin should be implemented in the treatment strategy.
Thank you. There is also another question about the use of metformin in a patients with solitary kidney, like after nephrectomy for some reason, and in dialysis patient.
Okay. Now, that's a challenging question. Metformin has been traditionally, let's say, contraindicated to be used in patients with advanced chronic kidney disease and in patients with dialysis for the perceived risk of lactic acidosis. However, this fear is somehow disproportionate, and this perceived risk of lactic acidosis is not perceived. It's assumed because it's cleared by the renal, but it's not let's say, not well referenced. And there are still some physicians who use the metformin 250, for example, mg/OD in peritoneal dialysis, and they use the 500 mg/OD after the dialysis session. So probably this is a time for the guidelines and the steering committee to rethink about the use of metformin in such scenarios. But now, as for now, to protect yourself legally, the standard guidelines is against the use in advanced kidney disease.
Thank you, Dr. Badur. Now, Dr. Raya, we're having also a couple of questions for you. There is a question about the use of SGLT2 inhibitor in patients with type 2 diabetes with a lower C-peptide level. So the question is saying, obviously, DKA incidence and with patients on type 2 patients with on SGLT2 inhibitor with a lower C-peptide levels is having high risk. Would you recommend evaluating C-peptide level prior to starting SGLT2 inhibitor?
Thanks, Asma. This is a very good question from Dr. Bashar. So basically, I think measuring C-peptide level in every patient with type 2 prior to starting SGLT2 inhibitor may not be a cost-effective. However, looking for risk factors to develop DKA would be a more effective and approach. So patients who have uncontrolled diabetes, high hemoglobin A1C, maybe it's worth to improve their glycemic control with the insulin before starting SGLT2 inhibitor. And patients who have, for example, ongoing reason to be admitted or going through several procedures, maybe delay their initiation. So I think looking for and addressing risk factors may be a more cost-effective approach.
Thank you. The other question is about what are the causes of DKA in type 2 diabetes patients?
Okay, so DKA in type 2 is uncommon compared to type 1. However, I think the classic provoking or precipitating factors that we see in type 1 patient also could apply to type 2, especially those who have uncontrolled diabetes and with the omitting their insulin doses. But maybe in type 2 diabetes, we may need to concentrate in certain condition, like, for example, steroid-induced DKA, pregnancy with euglycemic DKA or alcoholic euglycemic DKA, and also with the current use of checkpoint inhibitors that predispose to type 1 and maybe a previously diagnosed type 2 patient. Also, maybe type 2 could develop DKA if they have been wrongly labeled as type 2 and they could have LADA, for example.
Thank you, Dr. Raya. We're having also a couple of questions, but we'll move to Dr. Noor Al-Hassani. Is Dr. Al-Hassani still with us?
Yes, I'm here.
So, Dr. Noor Al-Hassani, are the downloads same for all pumps?
Are what?
The downloads same for all insulin pumps?
Definitely, the layout of the download is different from pump to pump, but it is almost the same idea of what information you need to gather from the download. So yes, I will advise you to check what is the most common pumps you are using in your own center, and based on this, you check what is how is the download or the layout of the download itself. So again, as we said, to know exactly from where you gather your main informations you need regarding blood sugar or the doses of boluses or basals, or for example.
Thank you. The other question is, do you have patients refusing insulin pumps?
Unfortunately, yes, we have. There are many parents, actually, they are not really convinced with technology, unfortunately. They are not, some of them, they're not ready to work more on this pump, which is, as we are saying, it needs to be monitored 24-hour, need to be checked the blood sugar and keep entering in the pump itself, the carb, the blood sugar readings need more of action, I mean. So yes, some of the parents, they are afraid from this technology, from any disturbance can result in pump failure and entering into a DKA or whatever. Other adolescents, they refuse to anything attached to their skin, whether in public or in privacy. Yes, unfortunately, we do have some are refusing the pump.
Thank you. Going back to Dr. Badur, we're having here another question for you from Dr. Bashar. TZD should not be used in elderly with osteoporosis, patients with history of macular edema, and patients at high risk of falls. Would you recommend a baseline BMD? And how about the follow-up? When you should repeat the BMD and how often?
That's a challenging question from Dr. Bashar Afendi. Now, that's true that in vitro studies, the TZD have shown that to inhibit the osteoblast function and activate the osteoclast function, that result, the net result is bone resorption. And that's true that there are reports of increasing fracture with the TZD, but there are studies that have shown that's true that TZD users have a higher risk fracture compared to non-TZD, non-diabetic users. But when they compared the TZD users to other oral hypoglycemic agents, there was a tendency to increase the fracture, like in leg, patella, tibia, fibula, but that was not statistically significant. And as we know, the diabetes itself is a risk factor for bone fragility because the glucotoxicity also inhibits the osteoblast function. So the association, the link between the TZD and the fracture I would argue partially due to the presence of confounding factor, the diabetes itself, and the reports that is not all the time consistent results with the statistical difference between TZDs and other agents. So to recommend for a screening, there should be, I assume, good number of people developing fracture with TZD to imply a screening protocol with the BMD, because screening protocols should always be like cost effective for frequently encountered conditions.
Okay, thank you. There is also a question about, would you prescribe, I think, SGLT2 inhibitors in elderly with osteoporosis?
Okay. Again, the SGLT inhibitors in vitro studies in embryo fetal cells, it have shown that the SGLT enhances the absorption of phosphate. So with absorption of phosphate, this promotes the secretion of PTH and the FGF23 that both have a phosphaturic effect. And the PTH have negative impact on the bone by causing bone resorption. And the FGFT23 blocks the end result of the active vitamin D that also have a negative impact on the bone. Now, when looking at the studies that they have shown the correlation between the SGLTs and the inhibitors, there are scattered reports of patella fracture, arm fracture, but not a major osteoporotic area. So the data is inconsistent, and it's inconclusive. So I will not block my patients with osteoporosis with SGLT until the data is more solid.
Thank you, Dr. Badur. Back to Dr. Raya. Is there any role for ringer lactate in the management of DKA? We're always talking about normal saline, but do you have an idea if there is any role of ringer lactate?
Well, most of the guidelines, basically their recommendation is there was no head-to-head trial, but I think there has been a small RCT comparing ringer lactate with normal saline, and it found no difference in terms of time to DKA resolution. This is what I'm aware of. So I don't know if anyone else is aware of any other study. So I don't think there is a difference.
What about the use of basal insulin? When patient is coming to the ER, we know that we're always giving a bolus of insulin IV per kg till we start our insulin infusion. Do you recommend starting full dose of basal insulin when the patient is coming, and when is the appropriate time of starting the basal insulin?
Okay, excellent. So we are actually, there is one point to stress here. When patients come with the DKA, the most important thing is really fluid resuscitation. So some people think that insulin is ahead of IV fluid. In fact, it's the opposite. You have to give IV fluids first. This is number one. Number two, most of the calls that we receive is regarding the night scheduled dose to receive in a patient who already in IV insulin, whether to give it or not. Yes, you can give it. If the patient is newly presenting, you start with IV fluid, you start with IV insulin, and then you can give him basal insulin. So the most important thing here is the IV fluid followed by IV insulin, and then the basal insulin can be given anytime. I mean, there is no specific time in my mind.
One more question, Dr. Raya. We saw from your case that ketone strips was very helpful in the diagnosis and management later on, especially when the patient started to be euglycemic, but still he was in severe acidosis. How do you think that would help us in managing patients with DKA, euglycemic DKA in future?
I think this is very good question, Asma. After actually this case, we have introduced a point of care DKA in our hospital, which have got the approval, but still not implemented. However, I think in such cases, ketone or ketone guided insulin titration would be a better option, because you will see that these patients will receive lower doses of insulin if we only titrate their insulin rate based on a glucose level. So I think it will have an effect. However, whether it will change the resolution or time for DKA compared with the other parameters, I'm not sure of really.
Thank you, Dr. Raya. Thank you. Dr. Noura, few questions. Which insulin pump you recommend for type 1 patients?
I do recommend insulin pump for type 1 diabetes in children, but there is no specific pump to recommend. It all depends definitely on the agreement between the physician and the patient himself or the parents. It depends on the patient age. It depends on the most concern issue they have. So for example, a child with more of issue concern of hypoglycemia, then I will prefer a pump which is suspending the suspend at time of low or before low. While on other hand, for example, as we were talking about adolescents who shy from showing the pump and so on, maybe it is useful to start a pump with the remote, so they don't have to display the pump itself wherever they go. So all it depends again on the individual himself.
Last question for Dr. Noura. What is the best basal-bolus ratio in insulin pump in young patients?
The best to start with, as we said, around 50 to 50 in general. And it is, again, in younger age, it is more of 30 or 40, up to 40% to 60 to 70%. This is to start with the insulin pump. Then later on, definitely you need to change it based on the patient profile, based on the review of his blood glucose readings, his meals, activity, and so on. So this is what we're talking about, mostly how to start with. Then later on, how to continue, it depends on the patient lifestyle more.
So thank you, Dr. Raya, thank you, Dr. Badour and Dr. Noura for answering the questions. We had much more questions. I want to reassure everyone, all these questions will be posted in the website. So please, our speakers, if you have time, just answer the question on the website. So thank you. By this, we're ending our Q&A and moving to our last part of our webinar tonight. This webinar will be ended by a topic about management of type 2 diabetes in special situation. Just a reminder for everyone, our sessions and webinar is sponsored tonight by Servier. The presentation now will be presented by Dr. Salah Habusnana. He's the Medical Director of Sharjah Diabetes and Endocrine Center, Director of Sharjah Diabetes Research Institute, Senior Consultant, Subconsultant Diabetes and Endocrinology and Acute Medicine. He's Head of Diabetes and Endocrinology Unit in University Hospital of Sharjah, Deputy Chair of Clinical Science Department and Professor in College of Medicine. Dr. Salah, the mic is yours. Please feel free to unmute yourself and share your slides.
Okay, thank you very much, Dr. Asma, for the introduction. I'll try to share my screen now. So I'll just so Dr. Asma, do you see my screen?
Yes, I do.
Thank you very much. So in the next 15 minutes, I'll take you quickly through management of type 2 diabetes in a specific situation. Just to show you my disclosure, this is sponsored by the sponsor surveyor. And when we look at the pharmacology and the research time and the discovery of the anti-diabetic medication, there was a time where only few drugs were available on the market. And if you go back to 1957, probably metformin and sulfonylurea. And by the advance of time to 2000, now we are in 2020, there is a plethora of the new classes like GLP-1, the incretins, either DDP4 or GLP-1 receptor agonist, and the SGLT2. And you can't name how many insulins we have on the market right now. The message of this slide, although those medications when it comes to the metformin and sulfonylurea are quite old, but they are still available and safe. And the important thing is that most of the intervention trials since 1960 included those medication, sulfonylurea. So if you look at how many studies being include the sulfonylurea, all those major landmark study sulfonylurea were included. So I will just take you as the theme of the tonight, the special situation and specific patient population. I will go quickly through the efficacy and the special situation where patients have issue with the hypoglycemia and weight gain, also those who they have cardiovascular and what are the cardiovascular safety issue with the sulfonylurea, and again those special population with the CKD, and I will see what the guidelines endorse when it comes to the sulfonylurea. So when we treat patient want to see results, and the results here is the efficacy of medication to get their blood sugar down to the control level. So when it comes to, again, what the most important factor in reducing the cardiovascular risk, what you can see on this slide is in stroke and acute myocardial infarction, and the top is the highest importance when it comes to risk factors or factor to reduce stroke and to reduce acute myocardial infarction. You can see the blood glucose control is the highest in blood pressure, physical activity, atrial fibrillation. And you can see you go down, the lower the risk is. So the more control of the above risk factors, the much better outcome when it comes to the cardiovascular diseases. So here is a network meta-analysis which look at 75 randomized controlled trials, and that's included most 33,830 patients with 11 oral anti-diabetic medication and 5 classes. And what you can look at here is the efficacy when it comes and the effectiveness. So still sulfonylurea is still very efficacious drug when it compared with the DDP4 inhibitors and some of the SGLT2 inhibitors. Of course, insulin, but if you look at the sulfonylurea class, you can see glycoside 1.37%, that's the average reduction of HbA1c. Now coming to the situation where the hypoglycemia and weight gain is an issue. And I have chosen this study, which is the real world study in patients with type 2 diabetes treated with a glycoside MR for those who are fast traumatized. So what this study address, there's 3 or 4 different points. First point is that the special situation here is a fasting Ramadan. Again, looking at the hypoglycemia, which is a very important issue for patients who they are on anti-diabetic medication. And the other thing is that it's a real world data. So we know randomized controlled trial is the cornerstone when it comes to sort of guidelines and evidence-based. But these days, the real world data is very, very important because it showed us the real world practice. So when patients come through, you don't know what they have. And again, there's like a real time when you look at those patients. So you don't choose whether they have renal failure or not, whether they have cardiovascular or not, or the follow-up of those patients is not like when they are in the randomized controlled trial, which is exclude most of the special situation and special population, especially those with the CKD and probably other complications. So the primary endpoint of this study is it's conducted by our colleague Mohammed Hassanein and a few authors. And the country were included is India, Egypt, Bangladesh, and the UAE, Saudi Arabia, Pakistan, Malaysia, Kuwait, and Indonesia. And the primary endpoint of this study is the proportion of patients with at least one symptomatic hypoglycemia event confirmed or not by measuring glucose concentration less than 3.5 or below. There are other secondary endpoints like the change in HbA1c, fasting plasma glucose, and weight between the 0 visit and the last visit. Proportion of patients with more than one confirmed hypoglycemia event, and proportion of patients with more than one hypoglycemia event, any event. Those are the inclusion criteria: type 2 above 18, those who they are on glycoside, and those who they are at least 90 days, and those who they are doing SMBG and willing to fast during Ramadan. Exclusion criteria, of course, the insulin, HbA1c higher than 9, and those obviously those the high risk patients who they can't fast Ramadan, and the other patients who they have contraindication to use glycoside. So the study design is like 2 visits, the 0 visit, which is the inclusion visit, where patients already treated with the glycoside MR 60 for at least 90 days, and the collection point at the end of the study, which is visit 1, and there are 3 periods: the pre-Ramadan period, and the Ramadan period, and the post-Ramadan period. So those are the baseline characteristic, which looks the usual patient that come to the clinic as it's real world data. So the mean age is 54, and females like 45% of the total. And if you look at the disease duration, 5.4 plus minus 5.7, and HbA1c 7.5 plus minus 0.5. So those are the common. If you look at the other cardiovascular therapy, statins, ezetimibe, ACE inhibitor, it's again contribute to like 34%, and it comes down when it comes to the beta blocker and the antiplatelet agents. It's only 91%. The number of the anti-diabetic treatment at the baseline, so if you look at the glycoside MR is 41%, and MR plus another oral anti-diabetic is 29%, and if they are sort of triple therapy is 29%. And what you can see the combinations, so the highest is the whatever those who are in glycoside as the this is the drug for the study, and GLP-1 receptor followed by the SGLT2 as a concomitant therapy with the glycoside. This is the average dose of the glycoside, 74 milligram, and you can see 60 milligram is the highest used dose in this study. This is the average HbA1c 7.5, but mainly it's below 7.5, which is 42.7%. And the second highest is 29%, where the HbA1c is 8% to less than 9%. So let us look at the primary outcome here. And what's the primary outcome is those patients with at least one symptomatic hypoglycemia, confirmed or not. So the pre-Ramadan is 2, and that's in person 0.2%, 2.2%, and 4, that's 0.3%. So lower rate of symptomatic hypoglycemia during and out of Ramadan. And if you look at the number, it's really low in comparison with the real hypoglycemia with the other agents. So the other important thing is there is no severe hypoglycemia during the study. You can see the confirmed hypoglycemia numbers, but when it comes to the severe hypoglycemia, it's 000. And when it comes to patients who they have at least one, you can see hypoglycemia, it's higher during Ramadan, and that's seen in the other studies as well, but not to the point where it becomes significant. Those are the secondary outcomes, which is the HbA1c. 0 visit is 7.5 down to 7.2. And when it comes to the fasting plasma glucose and the weight, there is a reduction in the fasting plasma glucose, and the weight is less, although it's not significant. That's the summary of the outcome. So this study is the first to show in a real world setting that people with type 2 diabetes fasted month of Ramadan treated with glycoside MR had no severe hypoglycemia and very low rate of symptomatic hypoglycemia while maintaining glycemic control and weight. Coming to the cardiac safety, although most of the old medication or the medication before the 2008, they didn't request it to have cardiovascular outcome safety trials. But if we look at the glycoside here and the advanced study, what you can see here, that's the with cardiovascular safety is quite safe in comparison with the others. And if I put them according to the other sulfonylurea medication, you see lower risk than for reference group when it comes to the glycoside in comparison to the other members in the class of the sulfonylurea. So patient with CKD, all of us know that's up to 50% of our patients, they have diabetic kidney disease. And those patients, they are really need to be treated specially, okay? And if you look at the glycoside and this graph out from the advanced study, and those are the component of looking at the progression of the CKD. So the new onset microalbuminuria lessen by 9%, and that's significant. When it comes to the new or worsening nephropathy, less by 21% with a significant p-value. New onset macroalbuminuria is less by 30%, and the end-stage renal failure is less by 65%. So risk reduction in renal events is quite significant and important. That's, as I said, come from the advanced, and we know advanced, there is advanced follow-up as well, which is showed the same. This results came from the advanced follow-up. So when it comes to the guidelines, sulfonylurea, they still mentioned in the guidelines frequently, and is still a line of treatment and with good efficacy. And again, if you choose the right patient with the right clinical scenario, metformin and sulfonylurea, they still have a role when it comes to the diabetes management, especially glycoside MR. Those are the different guidelines, which most of them, they mentioned the sulfonylurea, and the IDF guidelines 2017 and 2019, again, they said consider the first line metformin, sulfonylurea, or metformin as add-on. And of course, if patient got cardiovascular disease or CKD, most of the recent guidelines now is you have to look at the cardiovascular risk or the CKD, then you can decide whether patient might benefit from GLP-1 receptor agonist and SGLT2. What I would like to say at the end is, they are medication available, okay? And most of the medication we have, they address different aspects of the patient management. I think what we need to do right is choose the right patient for the right medication. So probably one of medication won't be approved for this patient, but it will be good with the other patient. There are lots of things involved here. The efficacy, the hypoglycemia and weight gain, the cost is a major factor when it comes to managing diabetes, especially with the number keep rising these days, and the prevalence is just shooting sky high. With that, I would like to thank you very much for your attention and for your listening. And I'll hand the mic back to Dr. Asma. Thank you very much.
Thank you, Dr. Salah. It was a great presentation. I would look in the chat if we're having any question directed to you. The question to you, up to what GFR level you will use diamycron?
Yeah, it's the GFR when it comes to the diamycron. And in fact, if you ask our nephrologists, they say it's quite safe till the, but 30 GFR, it's quite safe to use diamycron.
Thank you, Dr. Salah. That was the only question posted till now. So I think we're coming to the end of our webinar for tonight. Thank you all our speakers, Dr. Raya, Dr. Badur, Dr. Noura, Dr. Bahit, and Dr. Salah Abusnana. So I would like to thank Servier for being a great partner, sponsoring the ADS academic activities, especially the Young Leader Forum, and sponsoring tonight's webinar. Thank you for our attendees. We had a great number of attendees tonight. We reached up to 640 attendees. Excellent. And till now, we're having around 550 still remaining with us. Thank you, everyone, for attending tonight's webinar. Just a reminder that this webinar is CME accredited by DHA, and the CME will be available in 10 days. Please fill out all the evaluation form that will be sent to your registered email. emailed to obtain the CME credits. This webinar will be available on demand on the EDS Institute website and the EDS YouTube channel. Thank you for attending the EDS Young Leaders Forum. Please join us for our upcoming EDS webinars. EDS Patient webinar will be on 27th of November at 7 p.m. UAE time, and the topic will be about patients, diabetes care providers dialogue on type 1 diabetes. And our Young Leader Forum, next, the third one, is going to be on December 9th at 7 p.m. UAE time, and the topic will be about diagnostic and therapeutic approaches of adrenal disease. Thank you everyone again, and for further information, please visit the EDS website and the link and the address down below. Thank you and have a great night. Thank you everyone.